Today we will be discussing about residual ridge resorption in prosto. Have you wondered why old people keep coming back to us with their loose dentures? Or why the mandibular ridge resorbs faster than the maxillary ridge? So today we will discuss residual ridge resorption in a very exam oriented and simple way. So let's begin. According to GPT, a term used for diminishing quality and quantity of the residual ridge after teeth are removed is residual ridge resorption. Small tip, whenever you are writing an answer, always begin with introduction. So, whenever we extract the tooth, the alveolus is filled with blood and the clot organization begins in about your first week, which is then replaced with new bone, and the mucoperiosteum covers the bone and alveoli further. So there are two phases. The one is construction phase, that is while the fabrication of the prosthesis is being done, and then the post insertion adjustment phase. The prosthesis is fitted to the residual ridge, during which changes and reduction in the shape is seen, which is known as your residual ridge resorption, which requires maintenance phase and treatment, which is done by relining. So there are two schools of thought. One believes that residual ridge resorption is a pathological disease, whereas the other believe that it is a normal physiologic process. Atwood explained that it is rather a multifactorial process. Different pattern of resorption can be seen for maxilla and mandible. For maxilla, as you can see, the anterior ridge resorption is forward and backward with progressive bone loss, whereas for posterior region it is upward and inward. Please note that the incisive papilla remains constant and the anterior nasal spine ridge too. Now, one of the very frequently asked question is why the resorption of mandible is 4 times more than the resorption of maxilla. So first of all, let's look at its pattern. In mandibular anterior, the resorption pattern is downward and forward as you can see in the image, whereas in the posterior ridge it is downward and outward. Therefore, the mandible becomes wider. We will study a bit about Wool's law when you'll understand it even better. The reason why the mandible resorbs faster is because it has a smaller denture bearing areas, less vascularity, greater muscle attachment, and dense cortical bone. Atwood in 1971 gave a very important classification. As you can see in the image, he divided the residual ridge resorption into 6 patterns. The first one was pre extraction, then the post extraction, high well rounded shape of the residual ridge, then it becomes knife edge where the width decreases for the first time, then it becomes low well rounded, and finally it becomes depressed. So these are the 6 stages. The pathology of residual ridge resorption can be observed grossly or microscopically. Grossly, the patient will complain that his gums have shrunken, the size of the bony ridge has decreased under the mucoperiosteum. Gross finding on the dry specimen, which is left of the mandible or maxilla, will show external cortical resorption, which is uniform and smooth. Crestal area will show some porosity and imperfections, and there can be variety of shape and sizes as we discussed the one that the Atwood gave. And in cases of severe residual resorption, porosity of medullary bone can be seen on the crest of the ridge. It also leads to uncovering of inferior alveolar canal. So this below is an image which explains the method of predicting original alveolar crest height. In the microscopic pathology, we of course see clastic activity, that is, you can see many osteoclasts on the surface of residual ridge as it is a resorptive process. It will show a special feature, that is scallop margins of hair-shaped lacunae will be seen. So always draw this diagram which is shown and mention about the resorption bay, osteoclast and bone a bit. So this is a question which is asked in some competitive exams. Answer this MCQ in the comment box and let's see how much did you learn from the video. Evidence of external osteoclastic activity leads to gross bone loss. This is the pathophysiology of residual ridge resorption, and we need to write two important points, that is, it has convoluted walled appearance and it shows zone of even regular circumferential lamellae. So, according to the Enlow principle, you can see external resorption and internal deposition, which is depicted by a plus sign. Now, the outer surface will shrink, whereas the inner surface will expand. In case of maxilla, this happens, but in case of mandible, inverted V principle is followed. So, therefore, the maxilla becomes smaller and the mandible becomes wider. After extraction of the tooth, order 2 is seen and then sharp rounded edge. This is the same Atwood's classification. A bit more is explained here. You can write it in pathogenesis of residual ridge resorption if it comes as a long note. As we discussed earlier, that the residual ridge resorption is multifactorial. The factors are anatomic, prosthetic, metabolic, and systemic and functional. So let's begin with anatomical factor. There are two it can be divided into two, amount of bone and quality of bone. So according to amount of bone, as the patient's age increases, the chances of bone loss decreases as less bone is present. Now, according to quality of bone, the density is inversely proportional to residual ridge resorption. That is, more the density, lesser the resorption. The next factor is prosthetic factor, which includes the occlusal form of the teeth, the alignment of the denture teeth, the deformation of the denture base, the material of cause, and overclosure. Now we will discuss the functional factors. So there it is also divided into three parts. The first one is force. So more the force, more residual ridge resorption will be seen, and we can describe force in according to its frequency, intensity, duration, and direction. Muscular power also determines the residual ridge resorption rate, and of course the parafunctional habits. Now let's discuss the metabolic and systemic factors. Now we will discuss the metabolic and systemic factors. It can be bone disorders, stress, glands, or dietary factors. In bone disorders, the examples can be osteomalacia, osteoporosis, and disuse atrophy. So you can explain a bit about Wolff's law in disuse atrophy. Then the gland disorders like your endocrine disorder, thyroid, parathyroid, subadrenal gland, gonads. In dietary factors, vitamin A, B, C, D, minerals, and albumin. Usually, short note comes on osteoporosis. So, osteoporosis is due to disuse atrophy, bone loss from the hormonal cause or nutritional cause. It can be of two types: menopausal estrogen deprivation, or it can be due to the age changes. So, we have a very important formula: residual ridge resorption is directly proportional to your anatomic factors plus bone resorption factor divided by bone formation factors plus force factor divided by damping effect factor plus 1 by time. Now let's discuss the management. Whenever management is asked, always try writing prevention first and then the treatment. In some questions, also try writing the investigation. In this, you can write your x rays. So, in prevention, you need to write avoid locked denture occlusion, make careful occlusal adjustments, recall the patient to check the harmony of the occlusion. Now, the treatment can be written in terms of the general management, the one that the prosthodontists do, and then the surgical management. So, in the general management, we need to manage the attitude of the patient and then the systemic disorders. In prosthodontic management, we need to check three things: the mouth preparation, accessory aid to retention, the production of stable and retentive denture. So, in mouth preparation, we can do the tissue conditioning, that is, you can use liners. In accessory aid to retention, we can add magnet and springs for better retention. Now, for the production of stable and retentive dentures, Brill and Associate explained it in three things: pressure receiving surface, the secondary supporting surface, and the pressure transmitting surface. In pressure receiving surface, we should keep the posterior teeth narrow to increase the retention. The teeth should have low cusp angle. We can use inverted cusps or acrylic teeth, which gives the cushioning effect. In secondary supporting surface, two people explained fish and tuck field. According to fish, we can form series and we can use inclination. So, as we increase the inclination, the retention increases. In the pressure transmitting surfaces, if we do not relieve it properly, it may lead to instability. So, relief areas are important. The surgical processes used to increase the retention and reduce the residual ridge resorption can be increasing the height of the alveolus, and then if high frenal attachments are present, removing the frenal attachment, that is, we can do the pre-prosthetic surgeries, repositioning of the attachment of soft tissues of the mouth to the jaw. It is done to increase the denture bearing areas. Subperiosteal implant denture insertion can also be done. So if you like the video, please like, share and subscribe.